CheckMate-227 is a clinical trial that enrolled patients with non-small cell lung cancer and has a variety of pieces of data that we've seen in several presentations. The initial cut point for CheckMate-227 was patients who were PD-L1 greater than 1% or PD-L1 less than 1%. And the trial has gone on to divide those patients further by their tumor mutation burden. And the cut point in tumor mutation burden is 10 mutations per megabyte. 10 mutations per megabase. As the trial has gone forward, there are 3 arms in the trial in terms of treatment. There's chemotherapy, chemotherapy plus nivolumab, and an arm of patients who get ipilimumab plus nivolumab. Ipilimumab is the CTLA-4 antibody, and nivolumab is the PD-1 antibody. I think we've seen over the course of 2 big scientific meetings recently, both AACR and ASCO, we've seen that 2 different pieces of data presented. But it seems clear that patients with high tumor mutation burden seem to benefit most from the combination of ipilimumab and nivolumab. I think that the subsets of patients who are PD-L1 0 and PD-L1 1% or greater, among both groups, it does appear that those patients seem to benefit from ipilimumab and nivolumab if they had high TMB. In CheckMate-227, there are certainly multiple arms of patients. There were multiple biomarkers used. But in the group of patients who had high TMB, there was a clear correlation with benefit with ipilimumab and nivolumab. And that was significantly better than those patients who received chemotherapy alone. We've talked a lot about PD-L1 as a biomarker in patients with immunotherapy, but TMB, or tumor mutation burden, is also an important biomarker. How these interactions, or how these 2 biomarkers interact, is of course critically important to understand. One might presume that if you've heard that PD-L1 predicts patients who are going to respond, and you've also heard that patients with high TMB are going to respond, you might predict that those 2 biomarkers would overlap. But it turns out that it doesn't overlap very cleanly, and so there are a lot of patients who have no PD-L1 but have a high tumor mutation burden. And for those patients with high tumor mutation burden, regardless of their PD-L1 status, it does appear that they're going to benefit from immunotherapy, whether it's the combination of ipilimumab-nivolumab, or it's single agent PD-1, or a combination of chemotherapy and PD-1 inhibitor.
TMB is a somewhat controversial biomarker. I think we do have multiple data sets showing that it's a legitimate predictive biomarker. That's not that controversial to me. What's controversial is the optimal way to integrate it into clinical practice. The first question is, who do you test? If you're using next generation sequencing for non-squamous carcinoma already, then on most of the panels you're by default getting tumor mutational burden. The question is often brought up of, should I be testing squamous patients with next generation sequencing to get tumor mutational burden? I don't think that's an unreasonable thing to do, but to me, the data and the clinical applicability of the data have not passed the threshold that I'm going to get next gen sequencing on my squamous patients just to get tumor mutational burden. The next question beyond who you're going to test is how you're going to use it. And this is a very controversial area. I think what emerged from this study was that for patients with a high TMB defined as at least 10 mutations per megabase, Ipi/Nivo is a reasonable treatment to consider in the front line. In my practice, I would consider it for a very fit, very motivated patient with no immunotherapy contraindications. When you get into the PD-L1 negative TMB high patient, it gets a little bit more controversial. This is not a common population. It's about 16% of non-small cell lung cancer. And I think that, in my opinion, reserving the right to be very wrong as more data emerge, I think Ipi/Nivo is actually a fine idea for such patients. And then the final finding with regards to TMB from that study was that in the patients who were PD-L1 negative and TMB low, that all attempts to integrate immunotherapy failed to beat chemotherapy. Ipi/Nivo failed to beat chemotherapy alone, and Nivo chemotherapy failed to beat chemo. If you look at the numbers at risk at the beginning of those curves, you're talking about small patient numbers. However, that result does fit together with prior data sets showing very similar findings, and so I think it is likely to be true. And I think it would be reasonable to, if you had a patient with PD-L1 negative, tumor mutation burden low, to not expose that patient to the risks and expense of immunotherapy in the absence of likely benefit.
Since PD-L1 testing and TMB lead to identification of different groups of patients, it seems to me that we, going forward, are really going to want to know both pieces of data about a patient. We're going to want to know their PD-L1 status and their TMB status. So that you might identify a patient with high TMB, but no PD-L1. That patient should get immunotherapy. In contrast, you might identify a patient with PD-L1 that's 50% or greater, but low TMB, and the current data suggests that patient should receive single-agent immunotherapy as initial approach to treatment. I think we need to learn a lot more about how these biomarkers interact and how we can use them together to really predict the best patients to give immunotherapy to.